All right, guys. The dreaded anti-parasite drugs lecture. We'll talk about malaria, and then we'll talk about all the other things. Uh, Best advice we can give is actually just use Sketchy Micro because it's just they're weird names. They don't really know how a lot of them work. I would just go with Sketchy Micro for some of the other stuff. We're going to go in detail about malaria because there was like a whole lecture on it. But for some of those other things, we've actually included the pictures as well to try to help. So, parasitic general principles. So, all of these drugs are labeled as parasites, but not all parasites. Not everything in this lecture. Okay, hold on. I'm trying to make that square to rectangle analogy. So, all of these bugs are called parasites, but not all of these bugs are in the same class. I just ruined that. I'm sorry. So, for example, we have protozoa, which is just like a one-celled creature, Giardia, Antimobia, Cryptosporidium. Those are primarily our GI bugs that are causing some funky issues. We have Toxoplasma nigraria and Trypanosoma brucei. We have our heme guys, Plasmodium, which we'll be talking about shortly, is malaria and babesia. We have our STD, Trichomonas. And then we have some other sort of categories, Leishmaniasis and Trypanosoma cruzi. Man, I'm tripping over myself today. So then we have multicellular organisms, which are primarily our worms or helminths, round words being nematodes, tapeworms being cestodes, and flukes being trematodes. And then finally we have our mites or ectoparasites, scabies, or pediculus. So that was sort of just like a general overview of everything. That's in like our antibiotic everything lecture that we'll send to you guys a little bit later. But funny story, actually, we thought that a patient had scabies, and I shook his hand in the clinic, and it was the worst experience ever. So didn't have scabies, lucky enough, but wasn't fun. Was not fun. So start with a question. 23-year-old man presents to the emergency department complaining of an unsteady heartbeat. A prolonged QT interval is noted. The patient loses consciousness 30 minutes later. Shouldn't laugh about that. A repeat EKG is done, and it shows this image. What is this? Uneven. Looks like just a bunch of different random QRS waves fluctuating between large and small amplitude. Maybe torsades, prolonged QT, torsades. What kind of drugs can cause this? And specifically, if it's a protozoal infection that we're fighting, what kind of drug would cause? What kind of drug would be used in a certain protozoal infection? The answer is, well, we're just going to talk about malaria. So this is because of a drug that we use to treat malaria, not so much anymore, but we'll talk about why the Plasmodium is the answer shortly. So, malaria. Malaria scared the shit out of me, but I think the way we broke it down was pretty good, and we can sort of highlight the key points of where they're going to test you. So, to treat malaria, historically we can use chloroquine, specifically in the U.S. because there are not much resistance built up in the U.S. vis-a-vis, it's not really around in the U.S., save maybe Florida or the southern tip towards Mexico. So in the U.S., historically, we've been able to get away with using chloroquine against all forms of Plasmodium. Okay? However, the number one CDC choice is atocavone provigil, and I believe that's also what we talk in Sketchy. This is our number one choice for all forms of Plasmodium. However, this comes with the caveat: if it's Plasmodium ovale or vivax, you have to use primaquine because both ovale and vivax have the what is it called? They have the liver form, the hypnozoite. Think the drug. Those two have dormant forms that go into the liver and can just remain dormant. And the only thing that we can use to treat those dormant forms that live in the liver is primaquine. So just like the highest yield point of this entire malaria thing is if it's Ovale or Vivax, you have to use Primaquine in addition to other things, but you have to use Primaquine. That's the only one that will eradicate the parasitic liver forms. And I think that's like the highest yield point, and that's probably what they're going to test you is, you know, if it's a certain one, what do you have to add? And like, you have to remember that. So in the US, for all forms, falciparum and non-falciparum malaria, you can use chloroquine in areas without resistance. In chloroquine-resistant Plasmodium, in our notes, we go to quinine or IV quinidine, which are the same thing. Oral form quinine, IV form quinidine, plus doxycycline. Or if it's worse, we can use mefloquine, halofaltrine, or artenosate. Now, in Sketchy, just so that you guys can hold the two different concepts at once, in Sketchy, they say the way to go is atocavone proguano, IV artesunate, and quinidine. And that would be the order, depending on the severity of the infection. So in your notes, for chloroquine resistance, Plasmodium falciparum, it's quinine and quinidine, plus doxy. Sketchy, we have a different order. But as I said before, highest yield point. And we'll make this point again and again and again so it's clear. So just FYI, prophylaxis, it's pretty much dependent on like where they're going, where they're going to stay, and all these different types of things. We actually had a patient going to Nigeria this past week, and we gave them mefloquine because that's going to Nigeria. The recommendation per the CDC is mefloquine, and for the most part, clinically, you will look it up beforehand, or you can send them to a travel clinic. So this is just for your information. So we talked just a little bit. We'll talk a little bit just about how malaria works. You have a mosquito bite, and the parasite or sporocyte gets injected into your bloodstream, and it pretty much just goes into the red blood cell and it starts multiplying in the red blood cell. So we have drugs that can eradicate the erythrocyte form of the bug: mefloquine, chloroquine, doxy, and quinine. However, some Vivax and Ovale can become dormant and they can go into the liver. So you have hepatic bugs. The only thing that'll work for that is Primaquine. They do talk about metronidazole as a second line to Primaquine, but don't worry about that. Just Primaquine is needed if Vivax or Ovale is dormant and in the hepatocytes. At a certain point in the bug's lifestyle, they, in the red blood cell stage, they can actually become able to be taken up by the mosquitoes when they're in the bloodstream and then transmitted to somebody else. And that's sort of this major problem is, you have somebody who has malaria, the bugs are reproducing, a mosquito can come, take up some of your blood, go to somebody else, and sort of continue this cycle. When, I guess it would be the gametocyte stage, when the malaria bug is in the gametocyte stage, the one thing we can use for this is, the two things are quinine and chloroquine. But, major point, Vivax Ovale, hepatocytic Primaquine. So we'll just go through some of the major drugs. So chloroquine. Chloroquine has sort of a very interesting way of working. So the reason why malaria goes into the red blood cell is it needs to digest hemoglobin as part of its life cycle. So what chloroquine does is it's preventing hemozocin formation. So malaria is in the erythrocytes, it digests the hemoglobin, and it eventually is trying to form this hemozocin. Heme is sequestered as an insoluble malaria pigment as hemozocin. So if you inhibit it, the ability of heme to be converted into this substance, it's believed that there is oxidative damage to the parasitic membranes of the parasite, and that would lead to parasite death. It was a drug of choice before resistance as an effective blood schistonicide. So in its blood form of chloroquine, in malaria's blood form, it can kill this. It is efficacious against all forms of Plasmodium. However, if you have Vivax or Ovale, you need to add on that hepatocytic agent, Primaquine, because it could be dormant. Those bugs could have already multiplied into hepatic dormant forms. The resistance in falciparum is thought to be a P-glycoprotein pump, which is pumping the drug out of the parasite. Side effects are extremely important to remember. I want you to just sort of like link these two things together. Hemolytic anemia secondary to G6PD deficiency because of patients taking anti-malarial drugs. Chloroquine is one of them. You got fava beans, you have sulfa drugs like Bertram, and then you want to also add in malaria drugs. So you have your patient, it's an African-American patient who is jaundiced, just, came over, just started receiving treatment for malaria because they, traveled back to Nigeria or from Nigeria, and they're taking this medication, and all of a sudden they're jaundiced. G6PD deficiency malaria drug. Remember that. Very high yield. Can also cause blurred vision, and this one is actually safe for pregnant women. Primaquine, one of our wonderful malaria drugs where the mechanism is not known, possibly similar to chloroquine, causing oxidative damage to the cell or the bug. So this is the only available agent that's active against the dormant hypnocyte stages of Vivax and Ovale. Like, that is the most important fact of all of this, is that right there. Only drug that we can use for the dormant hypnocyte. So I guarantee you that's a question on the test in some way, shape, or form. Again, can cause some side effects, blood dyscrasias, cardiac arrhythmias, but not the answer to our question before, hemolysis or methylhemoglobinemia, secondary to G6PD. Pregnant women can't take this, and there's a caution for patients who are also on myelosuppressive drugs, history of granulocytopenia, and methylhemoglobinemia, methemoglobinemia. But for Primaquine, the most important thing to remember is this dormant hypnocyte stage of Vivax and Ovale. Mefloquine. Mefloquine is a very popular agent for travelers' prophylaxis. So again, mechanism not known, possibly acts as a blood schistonicide. So working on the blood, the hemoglobin form, the parasitic form that's in the hemoglobin. It is useful against P. falciparum and chloroquine-resistant P. falciparum, as well as other plasmodium agents. We've included this caveat as well because we just want to keep reminding you. Dormant hypnocyte stages, Vivax Ovale needs Primaquine. It can be used prophylactically in most malaria endemic regions with chloroquine-resistant strains. So this is actually the drug we gave to our patient who is the husband and wife couple going to Nigeria, is mefloquine. Side effects include anxiety, depression, and insomnia. Quinine or quinidine. So this is for our chloroquine-resistant falciparum. In notes, this is our first line. In sketchy, atoquavone and proguanil is first line. So P. falciparum and chloroquine-resistant P. falciparum, as well as all other plasmodium species. It is very useful. It has blood activity to the parasite in the blood, but it does not have activity against the parasite in our liver. So again, we're going to have to add Primaquine for Vivax and Ovale. It is not for prophylaxis because of toxicity, which includes schincusism. So this is very, very important. This was like our aspirin toxicity. It can cause tinnitus, headache, nausea, dizziness, flushing, visual disturbances, and QT prolongation. So for that first question that we gave you, our patient was on quinine or quinidine, had QT prolongation, which led to them having torsades. Very, very high yield. Quinine or quinidine can cause schincusism, which the primary thing you're going to look out for here is tinnitus or tinnitus. So if you have a patient with malaria and their ears are ringing or they're hearing a buzzing in their ears, it's most likely this toxicity and they're taking this drug. Or if you have a patient who is having dysrhythmias, specifically QT prolongation and torsades, they're taking quinidine. The last thing is you can get something called black water fever, which is a rare and severe hypersensitivity as the red blood cells and the parasites are getting killed off. We have some spillage and our body would react to that rupture and that spillage of contents, can cause sort of a hypersensitivity reaction, not necessarily to the drug, but to the treatment as the treatment is having effect. Almost like a tumor lysis syndrome, so to speak, as we're killing tumor cells, we have contents spill, and we have a secondary effect that occurs. This can be caused by quinine as well. A few more drugs. We have primethamine and proguanil. So we've also linked this with atocavone because this was our sort of sketchy micro first-line agent via the CDC. So proguanil is our folate synthesis inhibitor. It inhibits plasmodium dihydrofolate reductase. Can we remember 2 more drugs that are dihydrofolate reductase inhibitors? We talked about one last time. It was methotrexate. And then the other one is, I believe it's trimethoprim. But trimethoprim is only going to work in bacteria, and methotrexate is working in our dihydrofolate reductase. In this case, proguanil and primethamine are working on plasmodial dihydrofolate reductase. So it's effective against all erythrocytic forms of susceptible strains of all 4 malaria species. However, again, it's not effective against the liver parasites. So, we can't use it to treat ovale or vivax if it has dormant hypnotic liver forms. And it's used in combination with atocavone. Very well tolerated, but it can't be used in pregnant patients. And tocavone, another one, not known how the drug works, but it's used in combination with proguanil to give something called Malarone. It's the CDC's #1 choice for treatment and prophylaxis. It's effective against all erythrocytic forms of malaria, of all malaria parasites, again with the caveat not for liver forms. Has some GI toxicities. So we just have a few adjunct agents. Metronidazole. We know that metronidazole is used against our anaerobic bacteria, and it can form some toxic free radicals that damage the cellular DNA. Chloroquine reaches high levels of concentration and actually may improve its outcomes when metronidazole for hepatic abscesses. So we could get effectiveness of chloroquine on those hepatic plasmodium drugs or plasmodium bugs, but because we have our other guy here, we don't use it as much. Side effects include disulfiram-like reaction, which is the severe swelling, tachycardia, and hypotension, and it can also cause a metallic taste. Doxycycline can be added to quinine for the treatment, allowing for a shorter course of quinine because it is not very well tolerated. We know our side effects of doxy include discoloration of teeth in little children, inhibition of bone growth in children, and photosensitivity. And of course, there is a lot of interactions with taking concomitant milk or antacids or iron preparations with doxy. Finally, we have artemisinin. So this works by a heme-catalyzed reaction within the parasite that's producing a carbon-centered radical response for alkylating and thus damaging the parasite's macromolecules. Sort of a very complicated way to say we're, again, causing an oxidative reaction like many of the other malaria drugs. I wouldn't worry too much about that. Just know for drug-resistant P. falciparum and in severe infections. It's not used in combination. It can be used on its own, but it is. It is used in combination, not on its own, because at this point we need many different mechanisms to try to kill the malaria. However, not currently available in the United States, and you all know how I feel about when drugs aren't available in the United States. They don't really ask a lot of questions about that. So, we already sort of touched on this a little bit. 3 weeks after his return from India, a young African-American male presents to a clinic complaining of intermittent fevers and chills. After some blood work, it is determined that he has malaria and is given a course of chloroquine. Several weeks later, he complains of a short reprieve of his symptoms and then a relapse. The physician then prescribes him yet another drug, but he comes back in a week feeling fatigued, complaining of a change in color of his eyes, skin, like that in this image. We see some yellowing of the conjunctiva, scleral icterus. He's jaundiced, most likely having some sort of reaction. Why is this patient returning for the 3rd time? It's because he has G6PD deficiency, and he was given one of our malaria drugs that pushed him over the edge and caused that deficiency to occur. Very high yield, very important to remember this image, very important to remember this question stem. You will see that question, guarantee it.